Welcome to our webinar. We're going to be discussing how to support families of young children with autism. We'll touch on some early signs, some issues related to service navigation, and a good glimpse of some strength-based interventions. And our intention here is to try to have information that'll be useful for a wide range of medical professionals who might encounter children with autism in a wide variety of stages in their journey, and in different kinds of practice settings. So there may be individuals that you'll encounter who are young children really early on in the process, maybe even before a diagnosis, where parents have questions about early signs of autism. And we'll hopefully provide some useful information for those of you who encounter children in those circumstances. And we'll also focus on giving a glimpse into some high quality evidence-based intervention techniques, the kinds of techniques that we study and deliver here at Stanford. We'll give some examples. And our hope is that those of you who encounter children who've already had a diagnosis and who might be navigating service systems will really appreciate knowing more about evidence-based interventions so you can help families to identify high-quality interventions. Before I get started, I want to acknowledge that children with autism are extremely diverse. And actually, we use the term with autism, and we sometimes use the term autistic. And different people, different family members, and autistic people themselves have different preferences. So we're going to use terms interchangeably today to try to respect a wide range of perspectives. And we're also going to be sharing, as much as possible, a strength-based perspective. Our intention is to focus on supporting autistic individuals with their diverse skills and interests, and to show you treatments that really respect the individual. And we like to say, follow the smile. This is a term that Sally Rogers, who's a developer of one of the really effective interventions for autism, uses to talk about how important it is when we're working with an individual to know what they like and to lean into supporting them through their interests. So we're going to talk a lot about following the smile today. Here's a little overview of our intention. First, we're going to spend a little time talking about some of the earliest signs of autism, so that those of you in medical practice who might encounter very young children will be up to date with what to look for. We're also going to talk about supporting parents to navigate service systems, because it can be very overwhelming and confusing when a child is showing developmental delays, to try to figure out how to best help a family figure out all the pieces that they need to know to effectively navigate and get the services a child will need. And finally, we'll spend some time talking about the motivational behavioral strategies, particularly related to a type of treatment we call pivotal response treatment, that are helpful for improving a child's communication skills and improving social interaction with peers. Now, we know that from the very first moments of life, humans are wired to be social individuals, to crave and want and thrive with a rich social interaction. And for children who will develop a diagnosis of autism, this social interaction, although it can be very rewarding, might also be really challenging for that individual. And the better we can do to help a child from a young age to really benefit from and enjoy and relish the joy of social interaction, the better that child will be able to thrive throughout their life. So just like we would educate any child in how to read or how to write or how to do math, many times children with autism need extra education to help them really enjoy and benefit from social interactions. And their caregivers and teachers and therapists and medical providers also might need to modify the way that they interact with those individuals to help that child have a successful and enjoyable experience interacting with others.
Thank you for getting us started, Dr. Gengoux. So, like Dr. Gengoux was just talking about, right? It's important that we identify these early signs so that we can detect them sooner and then intervene faster. And that way we can provide support and interventions to families that can significantly improve outcomes for their children. So here we have a list of potential early signs for you all to reference and to keep in mind. The first one being showing poorly modulated eye contact. And so anytime that we see that, we want to make note of it and document it. And then at around 9 months, if a child does not show or respond to their name, or you notice they don't show facial expressions like happiness, sadness, or surprise, that's something that we want to flag as well. By 12 months, if you see that a child isn't using gestures, like for example, waving or engaging in simple games like peekaboo, that also should start raising some concerns. And then when a child is 18 months or older, if they're not pointing to show you something that they find interesting, that can also be concerning. Now, beyond these ages, as children continue to grow, more signs may emerge. So by 24 months, you may notice children not having language, or you may notice they don't show excitement when they're around other children. So again, those are just important things to note and to document. By 36 months, a potential sign could be not engaging in make-believe play or not copying adults or peers. Now, these signs are concerning, but they don't guarantee a diagnosis of autism. So we're going to be talking about the specific criteria for autism in a second. But I do also want to mention before I dive into that, that research shows that for parents who have a child with autism, the most common first concern that they share with providers is about language and communication development. So while not every child with communication delays will be diagnosed with autism, it is a good idea just to keep an eye out on children showing those early signs. And if you're ever concerned about a child that you're working with and want to review some of the signs, you can always visit the CDC website, and that provides a really comprehensive list. So yeah, we have it down there, and they have it's a really great resource for many different providers. So we found that to be very helpful. Now we can move on to the topic of diagnosis. And it is important to understand that autism is diagnosed based on observed behaviors. So it's not through a blood test, or at least not today. Maybe one day that will change. But right now, diagnosing autism requires careful behavioral observations. So more specifically, when we assess for autism, we're looking for two core areas. We look at social communication difficulties and restricted and repetitive behaviors. So starting with social communication difficulties, this may look like a child struggling to understand social cues, or having difficulty participating in conversations, or not engaging in reciprocal play. And some children with autism, or some autistic children, may speak fluently, but they might find it challenging to interpret social cues and to engage in social back and forth conversations, while others may rely on gestures or augmentative and alternative communication devices to communicate. So there's a wide range there. And then same for restricted and repetitive behaviors. You may see things like repetitive body movements, like hand flapping. You may see some kids having a strong fixation or specific routines or prefer interests. So for example, a child may insist on lining up toys in a specific way, or focus really intensely on one particular activity, or have a really great interest in something very specific, like dinosaurs, for example, or trains. Now, autism exists on a spectrum, like Dr. Gengoux was mentioning at the beginning of the presentation, and the level of support will vary from child to child. So now I do want to move on and talk about how you all can assist in this process of early identification, even if you're not an autism expert. And one of the best tools that we have are screeners. Here I put an example, the MCHAT, which is a modified checklist for autism in toddlers. And this is a simple screener that you can give to parents of children aged 16 to 30 months, and it can help identify some potential signs of autism. So the MCHAT asks parents a series of questions that can highlight some early concerns. So if you observe some of those early warning signs that we were just discussing, it can be helpful to follow up by asking parents to complete a screener like this that will give you a little bit more information. And ideally, we would use a system of universal screening whenever possible. So in fact, the American Academy of Pediatrics recommends universal screening for autism in primary care settings at 18 months and 24 months. But we know that's not always feasible. So if you work in a setting where universal screening is impossible, you could still offer something like the MCHAT to parents if they express concerns to you or if you notice early warning signs yourself. And it's just a helpful tool for catching potential issues early on so that we can ensure that children and their families receive the attention that they need. But even if you don't have access to something like the MCHAT, one thing that I want to talk about too is the importance of documentation. And so autism is a neurodevelopmental condition, which means that we need to see evidence of developmental challenges during early childhood. So when you document your observations, it's really helpful to be specific. So not just noting the things that concern you. For example, maybe you're noting a lack of babbling or poorly modulated eye contact, but also note any strengths that you see the child having. Like maybe they're showing interest in playing with you, or they're pointing to a toy that they're interested in and they want to share it with you. Maybe they're engaged in sharing enjoyment with their parents or with you in their room. So this information can be extremely helpful for providers when they're reviewing a child's chart and making decisions about diagnosis and next steps. So it can help with differential diagnosis, but it can also help inform interventions once we're going into the process of recommendations for families. And I will say this is especially helpful when we have families that come in with children that are a little bit older. And sometimes parents have a lot of trouble recalling specific examples from early childhood. So when there's been really proper documentation from other providers and we have that depth of knowledge from the chart review, for us who are doing autism evaluations, that's extremely helpful. Now, beyond giving this accurate diagnosis, what we really want, right, is to make sure that families are accessing the support that they need. So I do want to spend some time discussing what the process or journey of accessing care can look like for families. And as you can imagine, unfortunately, this is often a very long and hard journey for families. The average age of diagnosis in the United States is over 4 years old. And we know that children from lower socioeconomic backgrounds and ethnic and racial minority backgrounds are often diagnosed even later. And this delay can have significant implications for early intervention and development. So as you see here, there are many steps that families need to take and go through before a family can access services. So this includes being able to pick up on those early signs, expressing concern to providers, being screened, getting a diagnosis, and then finally getting access to treatment. And the wait list for autism evaluations are really long. So sometimes we're looking at wait lists that may be a year or more. And many services require a medical diagnosis to be given before insurance companies agree to provide coverage. So as healthcare providers and medical professionals, you're in a really great position to help accelerate this process. by placing appropriate referrals and guiding families to seek out a comprehensive evaluation as soon as possible. And we know from research that early intervention is so valuable. It's so important. I mean, there was a recent study in 2023 that was looking at and demonstrating that starting early intervention at 18 months instead of 27 months led to better outcomes in social communication, in language, and in daily living skills for toddlers with autism. And this shows that just a 9-month difference in the timing of diagnosis can have a substantial impact. And so that's why it's important to start the process as soon as possible. If you notice any concerns, talk to parents right away and start the screening process. And we know those conversations can be uncomfortable and hard to have with parents, but actually many parents appreciate it because it allows them to access services sooner. And I do also want to make a special note about bilingual families here, because unfortunately, when these families raise concerns about language development, they're more likely to be dismissed because there is a misconception that being raised in a bilingual household may explain the language delay. And this is not actually the case. So we want to be mindful of that and still document any concerns that families are bringing up and following up appropriately, just like we would do with monolingual children. All right, so after all this long road, and finally getting to the point of having a diagnosis, many parents may come to you and say, well, what do we do now so that we can help our child thrive? And again, as healthcare providers, you're in a really unique position to help them navigate this next phase of their lives because parents are likely going to turn to you for guidance on how to choose the right interventions for their child. And this is where you can help them understand the difference between effective, evidence-based treatments and those that may not be as beneficial for them. So it's a critical opportunity to provide them with accurate information and also with support, encouraging parents to read, to inform themselves, and empowering them to do something to help their children. So what does effective treatment look like? We're going to spend quite a bit of time talking about this now. But first and foremost, like I've already mentioned, early intervention is essential. So the earlier that we provide support, the better the long-term outcomes that we'll have for a child. But early intervention alone is not enough. Family participation is equally crucial because parents spend the most time with their children. They're the experts on their child. And so if we involve them in the treatment process and we ensure that interventions are carried out consistently and meaningfully, that's when we see good outcomes for the child and for the family as a whole. And another key component of effective treatment is the focus on natural environments. And this means intervening in places where the child naturally spends their time. So their home or in the community, which helps children generalize those skills that they learn to then real life situations. And then we also want to focus on teaching functional skills. So what does that mean? That means skills that are going to help the child navigate their environment and then eventually build greater independence. And finally, it's important that treatment leads to meaningful outcomes. So we want to ensure that the goals of an intervention are truly helping the child and their family, not just addressing isolated skills that may or may not have use. All right. So I want to start our discussion of effective treatment by talking about the landscape of intervention models and some of the decision points that providers, parents, and programs face when selecting the type of early intervention they want to use, because there's a lot out there. So one question to consider is, who is the leader in this intervention? And there are many interventions where the adult takes the lead, which can be effective. But research has shown that allowing the child to take the lead in therapy can have particularly positive outcomes. So child-led interventions have been shown to increase a child's motivation, to engage, and then sustain participation, and that can lead to greater long-term success in the skills that we're teaching. Now, another important consideration is where the teaching takes place. So while structured settings like a therapy room can yield positive results, when we intervene in the natural environment, meaning the places where children spend, most of their everyday lives, that offers additional benefits. So this helps with skill generalization and maintenance, meaning that the child is more likely to use the skills that they've learned in the setting that they're spending the most time at. And finally, we need to ask, what is the goal of the intervention? So it's not just about a skill building. We also need to focus on relationship building. So when we prioritize these relationships, we can enhance a child's motivation to engage in prosocial behaviors. And then this can also open the doors to new opportunities for the child, such as participating in group activities or interacting with peers in a meaningful way. And then for parents too, it gives them an opportunity to connect with their children, to understand them better, and to feel more effective in how they can support them. So one highly effective early intervention approach with a lot of research to back it up is naturalistic developmental behavioral interventions. And that's a mouthful, so we usually refer to it as NDBIs. And these are interventions that combine principles from developmental psychology and from applied behavior analysis. And they focus on teaching skills within the context of natural everyday activity. So there are many benefits to NDBIs. First, they promote generalization. So children are more likely to use these newly learned skills in real world situations, and they also increase motivation by incorporating the child's interest, making learning more engaging and more fun. And they focus on developmentally appropriate skills. So that way we're building a foundation for more complex abilities later on. And one of the key strengths of NDBIs is that they involve parents. And so clinicians train parents to use intervention strategies in daily routines, which leads to greater consistency and more learning opportunities throughout the day. And because NDBIs are individualized and they're flexible, they can be adapted to meet the unique needs of each child. And they also use natural reinforcers. So the learning is reinforced by the activity itself, making it more meaningful for the child and also for their families. So now I'm going to hand it back to Dr. Gengoux, and we're going to be hearing a little bit more about PRT, which is a specific type of NDBI.
Thank you. Thanks so much, Dr. Jimenez. So now we'll dive in. There are a lot of different kinds of treatments that fall under the category of NDBI, and we thought for today we'd give an example of a treatment that we do here at Stanford and that we study a lot, that would give you a good glimpse into how these developmental and behavioral principles are integrated together to form an effective treatment. So as Dr. Jimenez mentioned, these NDBIs use the principles of applied behavior analysis, and they incorporate a developmental perspective, and they're completed in the natural environment. And PRT, pivotal response treatment, is one example of an NDBI. And it's one of the 10 comprehensive models that's been recognized by the National Research Council for many, many years. And also when the National Autism Center did its National Standards Project, PRT was indicated as one of the established treatments. This is about 10 years ago, so the treatment has been around for many decades. And it's called pivotal because the goal is to try to pick target behaviors for treatment that are going to produce widespread gains across a wide range of functional areas. Our overall goal is to enhance the social motivation that children experience. So I'm going to give you a little bit of a practical example of how this looks. It is a behavioral treatment, and so because it's a behavioral treatment, it uses a structure for learning and for teaching that we call the ABC model. There's an antecedent, something that happens before the desired behavior, some kind of a prompt or teaching opportunity. Then there's a behavior that the child would exhibit. And then, very importantly, we want to make sure that when the child exhibits the appropriate behavior, there's a natural positive consequence that happens to reinforce that behavior and to make it more likely that the child will exhibit that behavior in the future. So I'll give you a little bit of an example here. For instance, we might have a kid who loves popcorn, for instance, and we might prompt the child, model the words, I want popcorn, or what do you want, some kind of a model. And then as soon as the child would answer and say, I want popcorn or popcorn, then the adult would go ahead and give that child the reinforcer, the positive consequence. Here's another example without food. We can do this with all sorts of different kinds of activities. So a parent might ask, what do you want? And the child might answer, tickle, or tickle me, mom. And then the parent might immediately go ahead and do the requested behavior, go ahead and tickle the child to reward that clear communication, that clear speech. So now I'd like to show you how the components of PRT fit into this ABC model. So we have 6 individually validated components to enhance motivation for learning. And the first one in the antecedent side, you can see, is that we teach parents how to provide clear opportunities when they're trying to get a child to respond. It's very important that they always have the child's attention and that it's very obvious to the child what he or she is supposed to do in order to get a positive consequence. And then after that clear opportunity, we think about 2 additional components on the antecedent side that boost motivation even higher. So first, we're always teaching during activities that the child is interested in. We don't make the child sit down and look at flashcards in order to learn. We follow the child and see what they're interested in. And if they're interested in tossing wood chips in the backyard, then we teach related to the tossing wood chips in the backyard activity. And secondly, we use a lot of what we call maintenance tasks, which are tasks that the child already has mastered or can easily perform. And the idea is that if we practice a lot of tasks that are easy, a child's confidence will grow and they will be more willing and able, more motivated to tackle harder tasks as well. And research shows it's a little bit ironic because when a child is behind in their development, we think we should focus on things that are difficult. But the research shows that by practicing a lot of things the child is good at, we can build motivation for them to try hard things. And then on the consequence side, we use that contingent reinforcement that's a classic component of ABA in order to be clear about which behaviors are being rewarded or which are the appropriate behaviors we would like to see more of. And to make it more motivating and easier, we also embed these 2 additional components to increase the motivation. So we always use reinforcers that are related to the child's behavior or their desired activity, and we always reinforce any reasonable attempt. And this combination, this full package, is the motivational components of PRT that help to help a child want to learn and want to come back for more. I want to show a little bit of the data that we've collected over the last decade or so to document how the effects of PRT and also to answer some of the questions about how effectively parents can learn PRT. I saw one question in our Q&A already about how long it can take parents to learn this ABC model. And you'll see the answer to that on this slide. So we completed a randomized controlled trial a couple of years ago. It was actually published in 2015, so it's been a little while now, with my colleague, Dr. Antonio Hardin. This was funded by Autism Speaks, and we enrolled 53 children with autism who also had significant language delay between the ages of 2 and 6 years old, and we assigned their parents to participate in either a group training for PRT, where they attended once a week for 12 weeks for about 90-minute sessions, and where they learned PRT through video examples and lectures, and they brought videos of themselves practicing PRT for feedback over 12 weeks. And we compared that group to the control group, which was a psychoeducation group where we were sharing information, general information about autism, different kinds of resources, and facts about autism, but not teaching a specific type of treatment. And on the left-hand panel, you can see the fidelity of implementation of PRT in these two groups, with the dark blue indicating the PRT group. And you can see after 12 weeks of just one time per week group parent training, we had a large percentage of it was over 80% of our participants met our 80% fidelity criteria for PRT implementation. So the vast majority of parents can learn how to deliver PRT with fidelity after about 12 weeks of treatment, either individual coaching or group parent training. And then on the right-hand side, you can see the effects of that treatment on their children's total verbal utterances spoken during a 10-minute laboratory observation. So in the dark blue, you can see that between baseline and then even by week 6 and definitely by week 12, there was a significant difference between the control group and the active group in the number of utterances that they were emitting during interactions with their parents in a laboratory setting. And a few years later, we did another randomized controlled trial where we also taught a number of parents how to do PRT, but this time we combined the parent training with an in-home therapy delivery model. This is a little bit more similar to the kind of ABA or early intervention that intensive early intervention that a child might receive in the community, where a clinician comes to the home and delivers the treatment, and there's weekly parent training. So the parents in the active group in this study received once per week parent training for the first 12 weeks, and then once a month parent training for a second 12 weeks, for a total of 24 weeks. And then the children also received 10 hours a week of treatment for the first 12 weeks, and they had 5 hours a week of treatment after that. And in our delayed treatment group this time, those children just continued with their stable community-based treatments. They continued to go to school if they were in school. They continued to receive other ABA if they were receiving other ABA or speech therapy or occupational therapy, but they didn't change their treatment. And we had 48 children in this study. A large percentage of them were Asian American children. And you can see from the Mullen scores and the PLS scores listed in the table that the children had significant developmental delays, as well as significant language delays. The mean for these scores, it would be 100. So when we see scores in the 50s, we're seeing multiple standard deviations below the mean. And here you can see in this graph the frequency of utterances that the children spoke in, again, in that same 10-minute structured laboratory observation with their parents. And you can see that by week 12, and to some extent maintained or flattening a little bit down by week 24 with the lessening intensity, but we still see group differences between the PRT group that's making a more significant change between baseline and week 12, and the delayed treatment group that's continuing their stable community-based interventions. And 91% of parents in this group, in the PRT group, met the fidelity of implementation criteria at week 24. And also, really interestingly, in this study, we administered a new assessment that's called the Brief Observation of Social Communication Change, which is a very rigorous evaluation of a child's core social difficulties or autism symptoms. And a lower score is better in this case. And actually, I see that we've also tricked you by making the PRT group in the red this time. But you can see that over time, there's a spreading, a difference growing between the delayed treatment group, which is relatively stable with their social communication skills, and the PRT group, which is getting less impaired over time, a little bit less impaired at the week 12 time point and considerably more difference from the control group at the week 24 time point. And this is really important because it shows that even when we target functional communication skills directly, if we're using motivational techniques, we're going to see a spread of effect across a wide range of social behaviors, even things that we didn't directly teach. And that's the sign the pivotal component of PRT is working, that we're seeing a spread of effect to things like joint attention and engagement and eye contact, gestures, other core social difficulties in autism are starting to get better, even when we're mainly teaching parents how to do the PRT related to their child's communication skills. I'm going to give you a little glimpse now of how we can use some of these same principles to target other types of behaviors. So, for instance, a child who's a little bit older might be ready to work on some academic skills, and we can really increase motivation by identifying natural reinforcers to incorporate into academic work, individualized for each child. So maybe we want to teach colors to a young child. We could do that using favorite foods. We might want to teach letters. We can have a letter printed on a favorite toy. You know, I like to pull out a container of Play-Doh and point to the P and ask a child, for instance, what letter is this? And then I can give the child that Play-Doh. We could teach spelling with electronics passwords. That's a great way. I worked with a teacher one time who was the kids, when they had free time in her class, were allowed to use a computer. And every day she would change the password to the computer, and it would be one of the spelling words for the week. And so the children would, if they knew how to spell the spelling word correctly, they would be able to unlock the computer. This is a really easy way to incorporate natural reinforcers into everyday routines. We can teach math with train schedules. A lot of children, I saw a comment about this in the chat, a lot of children have a lot of children with autism, for some reason, love trains. And I guess a lot of children of all kinds love trains. And this is a great way to teach natural math skills. So here's a couple of practical examples of how we could use natural reinforcement to teach academics or pre-academic skills. I gave you an example like this. So we could hold up a jar of Play-Doh, ask what letter is this? The child responds P, and the adult could give the Play-Doh. We could also, when we're having a snack, do something like say, let's count your grapes. And as the child counts 1, 2, 3, 4, 5, the adult could give the child the 5 grapes for their snack. So finally, what I want to turn to is to discuss how we can help to build meaningful interactions with peers. For many children, this becomes a major priority as they get further along into preschool or into elementary school. And certainly even for teens and adults, this is a really important consideration. So I'm going to start by talking about how this maps onto the ABC structure we're already familiar with. And so one thing we sometimes want to teach children is how to greet other people. This is actually a really challenging type of skill to teach, especially if what we want is for the child to learn to do this independently or to be motivated to do it independently. Because when you see it mapped out here, I could tell a child, say hello to your friend, and I'm kind of hoping that the child will respond, hi, Mark. But actually, there is no positive consequence necessarily for this behavior. And that creates a problem because the child might respond to my prompt or they might not. But if they're not very motivated to do it independently, they probably won't become much of a spontaneous behavior. So if I want to teach a child to say hello to someone, I'm really going to need to think, how could I make that more motivating? How could I put a reinforcer or some kind of positive consequence from the child's perspective into this consequence bucket? And I might do something like set it up so that the peer has a toy or an item that the child is motivated to play with. And if the child comes over and says hi, and then the peer hands the child a car to play with, that might feel a lot more motivating than just being told to say hi for kind of what might seem like no reason. A second challenge would be we want to teach kids to take turns. And sharing is especially hard for children with autism. They might not really have the core social motivation to share, and it might just feel like I'm giving away something that I want to keep. But if we can help a child take turns or even trade, that can be much more motivating. So, for instance, if I tell a child to take turns and the child gives a toy to a peer and says, "Your turn," I might want to set it up so that the peer is going to give another toy in return. And that trading is going to be much more motivating from a behavioral perspective than just sharing alone. So I wanted to summarize a few kind of key considerations when we're thinking about prompting for peer interactions. We know that social difficulties are very complex, and that if you're going to pick one thing to focus on in terms of teaching a child to be more effective socially, helping a child be motivated to make initiations to peers can be particularly pivotal for their success. There's good research to indicate that the prognosis for children who learn how to make initiations to other people is better. And so this is one of these pivotal behaviors that we like to focus on early on because we know it'll help lead to more success socially down the road. And when children feel that their interactions with peers are successful, then they'll be more motivated to try in the future. We actually worry a lot about young kids with autism who might try to interact with peers, but because there aren't appropriate supports in place, maybe their peers don't really know how to respond to them, they might not be successful and they might get discouraged or less motivated over time. So when we're thinking about improving social interactions, we really need to think about what kinds of cooperative activities we can build that are going to directly reward social interaction behaviors. And often we start by teaching requests because requests will be naturally reinforced. So I want to go into a little bit more detail about that. When we talk about initiations, there's actually 3 types of initiations. You can picture this cheesy little kid here by the balloon stand. And if he's making a behavior regulation initiation, he might be asking or requesting to have a balloon. Like he might just say, "Can I have the red balloon?" And that would be a request or a behavior regulation initiation. But he also might be making a joint attention initiation. He might be pointing because he wants to show somebody these beautiful balloons, and he might be saying, "Hey, look at the red balloon," right? And he might also just want to start up a social interaction or a conversation. He might just say that he likes balloons or that he has some balloons at home or remember his birthday party when there were balloons like these. We did a study a number of years ago where we taught children how to make requests in a social group setting. And we watched to see when they improved in their requesting behaviors, did they also improve in these other types of initiations? And happily, they did. When we taught the requesting in a motivating context, we saw not just improvement in the request, that's the red bar, but also improvements in the social interaction, the joint attention in the green bar, and in the responses to peers over just an 8-week period of weekly social skills groups. So this gives us, similar to the study that I showed you with the BOSC, where the children who were taught functional communication skills were actually also improving in their a wide range of social abilities. This shows us that if we teach these requests in a motivating context, we get collateral improvements in other types of social initiations, which are actually much more difficult to teach, much more difficult to motivate. And this is just one more justification for using highly motivating activities and contingent natural reinforcement when we're teaching social skills. So I'll give you an example, a little bit of how this might look. We call this cooperative arrangements. And the idea is that each person has some components necessary for completing the activity and that their interaction is reinforcing. So we might start out an activity with children having shared control of the materials or reinforcers. We might build a game around a strength the child already has. Like there's a great example of some playground games, for a child who's memorized all the capitals of the states in the United States. You might be able to build a playground game that requires that expertise, or you might even have the children bring an item to an activity that they can share. So we're all going to make ice cream sundaes, bring your favorite topping, and then you can share. And that way, the children, right at the start of the activity, have a reason to interact. The other way we do this is to facilitate ongoing cooperative arrangements during play. So I'll give you a couple of examples of how this might look. Like if we're all making our own personal pizzas, I might give the pepperoni to one kid and the olives to another kid and the cheese to another kid. And when one kid looks up and realizes that he needs cheese, that'd be a great opportunity for a clinician or a parent to prompt him to go ahead and ask for the cheese from one of his peers. We can do this with arts and crafts. I can give the scissors to one kid and the tape to another kid and the crayons to another kid. And when one kid looks up and realizes that he needs the scissors, he can be prompted to ask his peer for the scissors. And then as soon as he asks, he gets that contingent reinforcement, which rewards him for making initiations. And we can also design activities that where partnership is necessary. So we can do a three-legged race or a red light, green light with partners and things where the rules of the activity involve interaction. So the steps for increasing peer interaction are really pretty simple. We want to identify a time and a place to practice peer interaction, plan an activity that both children will enjoy, make sure we're building cooperation into that activity, and then as much as possible, we want to prompt these young children to initiate requests in an environment where the peers are going to be likely to reinforce their requests. And as much as we can adjust the setting, the activity, the duration, so that to promote successful interactions, because we know that friendships are most likely to grow from positive experiences playing together. So I know it's time for us to wrap up shortly. I'm going to share a couple of our favorite resources related to some of the intervention techniques that we've discussed today. So you already saw the image of this NDBI book, which was published a couple of years ago and is definitely a great resource. That's the one on the right-hand side. And then there's a book called Overcoming Autism, which is a great first introduction to how to navigate the diagnosis and early treatment process for young kids. It's written by Dr. Lynn Cagle, who is one of the developers of PRT, and also by a parent, Claire Lazebnik, who has a child with autism, and she provides a parent perspective in this book. So this is as much of a page turner about autism treatment as you're going to get. Encourage you to check it out. There's also a couple of more academic or more technical PRT books, like the PRT Pocket Guide, which is really like more of a treatment manual, and the PRT book in the middle with the teal letters is the one that's going to provide more academic citations and some more of the research support. We also have recently developed at Stanford a PRT online course. This is a self-paced course. It's mainly designed for individuals, for parents who have a child between 2 and 5 years old, and it mainly focuses on improving PRT implementation to help with communication skills. But you're welcome to check out the registration and a little bit more information on our website for this course. We also have a resource at Stanford that you're welcome to take advantage of. This is called the Early Support Program for Autism. This is a collaboration with the Children's Health Council here in Palo Alto, and it's funded by the John and Marcia Goldman Foundation. And this is a program that's been going on for over 10 years. It's a resource navigation assistance for families. We have some parent training that's offered, as well as meeting with a clinical care coordinator. This can be done via Zoom. It's free of charge. There's no wait list. Any family can call, any provider can call or email or submit an inquiry online. And you're welcome to take advantage of this to try to help find resources for families that you might be working with. We have a couple of research studies going on that are active at Stanford. Here's an example. This is a SPARK study, which is a collaboration really across the United States of different universities. And this is a genetic study of autism. So you might be interested in referring some of your families. They do saliva collection. They can mail a kit to the family if the family is interested to learn about the genetics of autism and to contribute to the science understanding better genetics of autism. And finally, we have a wide variety of clinical trials. You can go to autism.stanford.edu to check out our open research studies. There are a number of studies that are open to families in the Palo Alto Bay Area, and then a few studies that are open to families really across the country and in Canada. So feel free to refer families to check out this website. And finally, I'll acknowledge our collaborators. I mentioned Dr. Antonio Hardin, who is the PI of several of the studies that I mentioned, and I've listed members of our research team. We have a really large research team, many of whom are not on this list, but want to give a shout out to all of the families who participate in our research studies and help us learn more about effective treatments for autism. And with that, I'm going to pause. And I know we've got a lot of great questions in the chat or in the Q&A section. So we'll have about 15 minutes to go through and answer many of these questions. We'll try to get to as many of them as we can. But thank you so much for listening. All right. I think what I'll do, maybe Dr. Jimenez, if you see any in here that you'd like to answer, let me know. I'm going to start with one that came in right away. So the question is whether congenital neurological conditions like Fragile X syndrome or prenatal exposure to toxins influence the development of ASD later in life, and how can early neuroimaging and genetic screening help identify at-risk children for earlier intervention? And this is really, I would say, a work in progress. So we know that that many children with autism will have a genetic cause that can be identified for their autism. And Fragile X is one of them. Many children with Fragile X might also have a diagnosis of autism. And there are a handful of other pretty well-known genetic causes of autism. So it is considered a standard best practice for young children with autism to have genetic screening. I mentioned the SPARK study, which is one way to do it, and we can also do clinical genetics. Neuroimaging is not quite as clinically fruitful at this time, although we certainly hope that that will be different in the future. And the children who do have genetic conditions might be at risk for other types of medical issues, there might be seizure disorders associated with certain genetic conditions. So it can be very helpful to work with a clinical geneticist to refer families for counseling related to their genetic condition.
I saw two questions that were sort of related, so I think I can answer both of them. One of you was asking about, well, what do we do when a child is asking for up and we're at the zoo and we can't really take them up, right? And then the other one was kind of gauging out, well, what do we do if the child starts screaming for something and we can't give it to them? and then we give in to the screaming, which I think could be related. And I will start with the first one. There are some times where we won't be able to reinforce the child's language in a specific circumstance because either it's impossible, we don't have access to what they're asking for in that moment, or because it's dangerous. And in that case, we can offer them different options and we can try what we call redirection of attention by trying to make something a lot more fun and trying to get their attention to something different. And this is also a way of helping a child distinguish between different moments where they may be able to request for something and moments where they may not be able to. And sometimes they will get frustrated, and that's okay. And we help parents navigate that by staying calm and helping their child co-regulate with them, and then helping them make an attempt to ask things nicely that the parent can give, and then we can instead reinforce that attempt at language instead of reinforcing the screaming, which I can't find the question right now, but you're right. If we are reinforcing the screaming all the time, then children may learn that that is the way to request things, and we don't want to teach them that.
I saw another question that a couple of people upvoted. So, examples of autistic behaviors in very young children often describe typically male behaviors, such as lining up toys, interest in dinosaurs and trains. Are there good examples that are more typically female? And one of the things that this question reminds me of is to acknowledge that the diagnosis of autism is much more common in males. So there are probably 4 or 5 times as many males diagnosed with autism as there are females. And so you might see this that reflects this question that sometimes when we talk about behaviors in autism, we're often talking about boys because many of the children with autism that we see are boys. Now, it's it's important to acknowledge that there might be underdiagnosis of autism in females and that there are a lot of research studies going on to try to understand the unique presentation of autism in females. So that's an area of active research and investigation. Now, children, males and females, play with all sorts of different things, but you very well might see a child exhibiting some of the same kinds of self-stimulatory behavior, insistence on routines, repetitive behaviors with toys that might be traditionally played with by girl children. So, for instance, I was working with a child recently who was really interested in lining up all of the different parts of her tea party. And so she had, rather than pretending the way another 2 or 3-year-old child might do, she was still playing with the teacups and the saucers and the teapot, but the way she was playing was by lining them up all in a row and getting very upset when that line was disturbed. So the same exact behavior you might see a girl or a boy do with cars, this is a child who might do that with her tea party. I think we saw another one. There was a question about with the backlog in evaluation, do you see AI-based programs being approved for diagnosis and covered by insurance? And absolutely, that is likely to happen. There's a lot of companies really right now working on leveraging technology to improve diagnosis for autism. I would say we haven't arrived yet at where we hope we might be in terms of the rigor with which those programs are evaluated and the confidence that we can place in the diagnosis. So I would suspect that for a while we'll still see a hybrid model where clinicians might use technology tools, but also still be making the ultimate clinical decision. At this time, the diagnosis by a licensed clinician is really a critical part of the diagnosis process. But we are optimistic that with rigorous evaluation and testing, that new tools might become available that would help many, many more families receive access to diagnosis and ultimately to treatment much more quickly.
Yeah, and I will say, the last conference that I attended, there was someone presenting on something like that that could be applied to primary care, where a video of a mother and a child or a parent and a child could be looked at through an AI system, and it could start giving some signs that then clinicians could follow up on. But like Dr. Gengoux said, it would also require a professional to evaluate the child afterwards.
There's another question here about what are the benefits of diagnosis in older children who've gone through school thus far without issue and have created some relationships outside their family. There are many parents bringing up concern in older children now and are requesting evaluations. And also, what can I do to screen these children in a general PCP office? Dr. Jimenez, do you want to speak to that one, or should I take it?
Sorry, can you start taking it? I was looking
Oh,
at a
yes.
different question. I got distracted for a second.
No problem. Yeah. So absolutely. When children have more severe impairments, either intellectual disability or language delay, it's likely that their trouble will get identified earlier, hopefully. But for children who have an intact intellectual ability or might not have a significant language delay, the symptoms of their autism may not present or the symptoms of their autism may not become evident to other people until a little bit later. Like Dr. Jimenez had mentioned in our talk, it's true that if there are no symptoms in early childhood, then whatever is going on is not autism. So we do have to verify that there was a developmental delay early on. But if there was a developmental delay that didn't get detected until the challenges in the school setting, for instance, became more difficult, or if for some reason it was a misdiagnosed, then yes, a child could present in an office with concerns for autism that haven't been diagnosed much later. And it's absolutely a good idea to take those concerns seriously, and that really would warrant referral for a full diagnostic evaluation if a parent or a clinician is concerned about symptoms of autism in a school age or teenage individual. There aren't going to be easy screening measures that are going to definitively tell you whether a child meets full criteria for autism in that age range, especially if they are higher functioning with the language and the cognitive abilities. So referring them to a specialist is really going to be the best choice.
And I will add on to that the benefit too is that with a full evaluation, even if they don't end up with a diagnosis of autism, for example, there are certain things that are picked up on, like trouble with social interactions that maybe doesn't get to the degree where we would warrant a diagnosis. But still, if we see that that is an area that a teen needs some support with, then that can inform interventions as well, regardless of the diagnosis. I did see a question here about language and raising a child in a bilingual household, potentially exposing them to a third language and whether that would be recommended or not. And we can give a specific recommendations for a family. I would encourage you to talk to your providers. But what I will say is that there are no known things that would come that are like bad or worsen a diagnosis by exposing a child to a third language. And so what we know about bilingualism is that it actually promotes a lot of flexibility, cognitively speaking, for children. And so it's great when we have families that are bilingual and that are exposing their children to multiple languages. So we never discourage that.
I saw another question about whether autism includes all forms of neurodiversity. The person was wondering if the terms are interchangeable and mentioning that some patients would escape detection until much later in childhood or adolescence if they don't have developmental delays or are even higher achieving academically. So to the first part of the question, autism is one example of neurodiversity, but neurodiversity is a broader umbrella term. So there might be a variety of other kinds of diagnoses, maybe ADHD or other kinds of learning differences that could fall under the category of neurodiversity. And there are also people who would consider themselves neurodivergent who really wouldn't meet full criteria for any diagnosis at all. So I would think of the term neurodiversity as being a pretty large, broad umbrella term, and the category of autism diagnosis would fall underneath that as just one example. And it's absolutely true that the milder the symptoms and the less functional impairment, the more likely it might be that a person would not receive a diagnosis until later in development. But the if there's no evidence for any difficulty, any developmental delay in early childhood, then the person wouldn't technically qualify for a diagnosis of autism. All right, it looks like we've got a couple minutes left. I know there's going to be some um, some questions that we won't get to, but we'll try to answer just a couple more. I think that I see one here. Can a child have ASD despite having no genetic evidence? Also, when a child with ASD asks for something, should you wait until they're older to work on manners such as please and thank you? So I'll try to hit both of those kind of different questions really quickly. So yes, although there have, to the first question, can a child with ASD have ASD without having any genetic evidence? Yes, there have been about like 200 different genes associated with autism, but most children with autism at this time, when they do get genetic testing, we don't detect genetic or abnormalities. So you might find in 5 or 10% of cases a known genetic cause for the autism, but in many, many children with autism at this time, we don't know. It's the genetics of autism are likely very complex, and they're not fully understood at this time. To get to the second part of the question, when a child with ASD asks for something, should you wait until they're older to work on manners such as please and thank you? We try to individualize treatment as much as possible based on the child's abilities and also the parent and caregiver priorities. But it's often when functional communication is a priority, we might delay teaching something like please and thank you and go ahead and reinforce a child who's making any attempt at all. And you saw in our presentation some examples of children who were asking with single words, just saying up or just saying down or just saying spoon. And there's no reason to force a child to say please and thank you. Any appropriate, reasonable attempt is great to reinforce when a child is learning. And when we reinforce those reasonable attempts, children will be more motivated in the future and eventually learn how to say please and thank you too. All right. I know we're right at time, so I apologize for those questions we weren't able to answer, but I hope you enjoyed the presentation and thanks so much for joining today.